Hello, my name is David Hovsepian. I'm an interventional radiologist here at Stanford. We've been performing uterine fibroid embolization for over a decade, and Stanford has been one of the nation's leaders in this area. In the next 30 or 40 minutes, I'd like to tell you about our experience here, what you can expect as far as outcomes, and what you can expect on the day of your procedure, and try to answer any questions that you might have. We're also providing for you written information that you can take with you and refer to before, during, and after your procedure if you have any questions. Since 1998, we've been performing uterine fibroid embolization here at Stanford and have treated hundreds of patients. And as the nation and the world has also noted, this is a definitive treatment for women in about 85 to 90% of cases. Most women will have enough relief of their either menstrual symptoms or their bulk-related symptoms that they don't seek any further treatment. And that's a great track record. You don't see a lot of things in medicine where you can talk about 90% success rates. Uterine fibroids are exceedingly common. Probably 20 to 40% of all women in America have uterine fibroids. Fortunately, only about a quarter of them are symptomatic. Most of them present with bulk-related symptoms such as urinary frequency, abdominal bloating, or pelvic pain, which is typically worse around the time of menses. Also, very frequently, they experience bleeding complications, very heavy periods, very painful periods, passage of large clots, although typically bleeding in between periods is not very common. Uterine fibroid embolization is helpful at relieving both of these categories of symptoms, and as we'll see, is rapidly becoming a very important tool in the armamentarium of fibroid treatments. Approximately 600,000 hysterectomies are performed annually in the United States, and about a third of those are for fibroids. The cost of that has been estimated as high as $4 billion, so this is a large medical cost with a lot of implications as far as cost-effective treatments go. Approximately 47,000 myomectomies are performed annually, and that number is increasing. That's surgery to remove just the fibroids, but to preserve the uterus. And there are approximately 15 to 17,000 uterine fibroid embolizations performed annually in the United States, and that number is rapidly increasing as awareness of this procedure increases.
Am I a candidate for this procedure?
Most patients who come for this procedure are asking me the same question that their gynecologist is, and that is, am I a candidate? And my answer to most women is, when would you like to schedule? I know that sounds like a joke, but most women are candidates for this procedure. The typical patient has a uterus that's 12 or 14 weeks in size. That's comparing it to a normal pregnancy. This is the point at which the bulk symptoms have reached a level that requires some form of intervention. You are having urinary frequency to the point that every time you walk into a building, the first thing you look for is, where's the bathroom? So the embolization procedure, the women who come for evaluation typically are very similar. Most think that they're very different, but most of the time the uterus is 12 or 14 weeks in size. They've reached a point where they really need to do something. What uterine fibroid embolization does is it typically turns the clock back by about 5 years. So that's generally a point before which symptoms had reached a point where you really needed to do something about it. So when we evaluate women for candidacy for this procedure, we really want to figure out who aren't candidates. And that group, as I said, is really very small. Obviously, if you're pregnant, that's a no-brainer, but there are other contraindications such as impairment of renal function, allergy to contrast, a bleeding problem, or you're on blood thinners, most of which can be corrected. So even these relative contraindications are usually not a reason not to do fibroid embolization, and in fact, those are often the reasons not to do surgery, and which make fibroid embolization a more attractive alternative.
What symptoms are common in a woman with uterine fibroids?
The symptoms, as I mentioned, fall into two general categories. That is either menstrual problems or bulk-related symptoms. nobody really understands why fibroids cause bleeding, and even very small submucosal, those are the fibroids on the interior of the uterus, can cause symptoms. And as you can see from the cartoon on the right, the interior of the uterus is at the bottom, and even a very small fibroid can compress the tiny veins that line the endometrium and cause congestion and lead to bleeding. Most of the other fibroids that arise in the wall of the uterus or on the exterior have to reach a large enough size that they can compress a vein and cause that same degree of congestion. So we find in general the bleeding symptoms are caused by submucosal, that's interior fibroids, or intramural fibroids, those are the ones in the wall that have reached a very large size, and it's the subserosal or external fibroids that balloon off and compress the adjacent structures that are the ones that are responsible for causing bulk-related symptoms.
What are my options?
Currently, there are a number of options. All women have options. Which one is appropriate for you depends on the size, location, and symptoms that your fibroids are causing. Most gynecologists will start to try to improve fibroid-related symptoms using hormonal therapy, either to regulate the menses or to stabilize the endometrium or to get you to stop menstruating altogether. And these have a variety of side effects, and some of them are appropriate in the short term but can't be used long term. So hormonal therapy is the first line of treatment, but is often not definitive. Hysterectomy is the right choice for a lot of women who have symptoms that are bothersome to the point that they need to do something definitive and really cannot undergo intermediate therapies, or there are surgical risks that prevent them from being candidates for major open repair. Some hysterectomies can be done through the laparoscope, but oftentimes the uterus is large enough and there are multiple fibroids that precludes doing a laparoscopic procedure, and so a large midline abdominal incision or bikini incision is necessary, and that usually entails a recovery period of 4 to 6 weeks. So most women, especially those who are desiring to preserve their fertility and future childbearing, will look for uterine sparing alternatives. Uterine fibroid embolization is one, and there are a number of surgical treatments that are also uterine sparing, such as myomectomy, laparoscopic or hysteroscopic, as well as a number of fringe therapies such as cryotherapy, heat therapy, and MR-guided focused ultrasound, which is just now receiving some attention, but is still in the initial stages of investigation. The hysterectomy is a definitive repair. You never have fibroids again. You don't have any bleeding symptoms again. But for a lot of women, the surgery is a lot to recover from. They may not be able to take that amount of time off from work, and certainly there is a loss of gender identity and an association with the loss of female pelvic organs that patients often don't want to undergo surgery because that is too invasive an option for them. Laparoscopic myomectomy is probably the least invasive of the surgical techniques. It's limited somewhat in terms of size and number of fibroids. 10 centimeters is typically the largest that you can remove, but fibroids that are up to 15 centimeters sometimes can be removed laparoscopically. The problem with myomectomy is that in some cases, especially if the fibroids are too big or too near the cervix and difficult to get to, that a myomectomy can turn into a hysterectomy, and that defeats the purpose of trying a uterine sparing strategy. The laparoscopic procedures are all much easier to recover from than open repair, and typically they have fewer postoperative complications, especially adhesions and bowel obstruction that may result afterwards. So the downside is that you often leave small fibroids behind that can later grow and become symptomatic. So the need for additional procedures is as high in some series as a third of patients. The myomectomy is the standard of care for women who are desiring future childbearing, and it has the potential to preserve fertility, although in many cases the number and distribution of fibroids causes scarring afterwards that prevents pregnancies from taking place. So while it is the best line of therapy if it is feasible, occasionally it will result in infertility, and alternatives such as uterine fibroid embolization may be preferable. The myomectomy, as I said, often misses the culprit lesion, especially if the problem is bleeding. Certainly large bulky fibroids can be removed, and that will relieve the bulk symptoms, but you often miss the lesion that is responsible for bleeding. If the fibroid is small and in the interior of the uterus, frequently those can be removed through the hysteroscope. That's a scope looking up from below without an abdominal incision, and cure can be effected that way. But that's a small percentage of fibroids overall. Most of them originate in the wall, and it's only when they get very large that they start to cause problems with menstrual flow and bulk-related symptoms. As I mentioned, MR-guided focused ultrasound is receiving a lot of attention because it is a non-invasive, truly non-invasive way of taking care of fibroids. And as you can see from the images, you're not positioned with your head in the magnet. So for women with claustrophobia, this is not an issue. The downside right now, there are two. One is that insurance is not yet reimbursing for it, and also the patients who are candidates for this procedure are limited because the fibroids have to be located in the front, close to where the ultrasound beam is, and you are limited in terms of the size of the fibroids that you can treat at one time. The recovery, though, is very quick, and women are home that same day and back to work the following day with very few side effects. So I think we're going to be hearing more about this for some women.
What does this procedure entail?
Let me tell you a little bit about the embolization procedure itself. And again, all of this is in the booklet that you've been provided. The procedure uses standard techniques, FDA-approved equipment, and embolic agents, and is covered by most insurance carriers. It takes typically about an hour. You generally do not feel anything during your procedure. It's really afterwards that you notice some cramps and discomfort, very similar to a menstrual period, and for that reason, I admit all patients overnight. An intravenous is connected. Medications are given for comfort, relaxation, inflammation, nausea, which sometimes occurs, and in general, patients do very well. It's really the first 4 to 6 hours that can be uncomfortable. After that, usually there is enough symptom improvement that you really are very comfortable. A lot of women are eating dinner that evening. Almost all are converted to oral medications the following morning and home by lunchtime. The procedure is a catheter-based therapy. That means that we go in just like a cardiac cath with a small catheter that goes in through the femoral artery, which is the artery at your groin. The catheter is advanced on the inside into each uterine artery. You have 2 uterine arteries, and the embolic particles are delivered in a controlled fashion while observing fluoroscopically. So the risk of the particles going where they don't belong is essentially zero. The catheters that we use are measured in millimeters in diameter, so they're of such small size that the risk of any kind of injury is low, and you don't feel anything during the procedure because you don't have nerves on the inside to perceive what we're doing. The anatomy, as you can see from the diagram, is fairly complex in the pelvis, but fortunately the uterine arteries are very recognizable by their course and usually very easy to get a microcatheter in and successfully embolize without any risk for injury or technical failure. The embolic particles that we use, as I mentioned, are FDA approved. They're typically small spheres that are made of a plastic polymer. They're designed to be permanent. They're injected in free flow, so they're carried to the periphery of the uterus, and the entire uterus receives a dose of particles so that fibroids, whether they're large or small, are all treated equally. We're not targeting individual fibroids. We're blanketing the uterus with particles, sort of starving it for oxygen and nutrients. And the trick with this is that the uterus is able to recover fairly rapidly because we don't block off the blood supply completely, but the fibroids themselves are living on a very tenuous blood supply and are not able to sustain themselves for very long without adequate oxygen, blood flow, and nutrients, and they essentially starve to death. That's when the process of shrinkage begins. It courses over several weeks, and usually by 3 or 4 weeks, enough shrinkage is noticed that you'll see an improvement in bulk-related symptoms. The first period is typically lighter, and then with each successive cycle, the periods will get a little bit heavier, a new baseline will be established, and by about 6 months, the fibroids have been completely broken down and replaced by a rubbery, soft scar tissue material called hyaline, which is spongy, and it's really the change in consistency and the softening of the fibroids that produces symptom relief as compared to the actual shrinkage per se. And sometimes with even only modest shrinkage, you will find complete resolution of symptoms. The only symptom that you may not see improve is if you look at your abdominal girth. If you look at yourself in a mirror, you may not notice your stomach getting any slimmer, but you will notice that your clothes no longer feel as tight, you're able to lie on your stomach at night, and in general not feel as bloated around time of your periods. So if the only symptom is cosmetic, this is not a good procedure for you. You'll be disappointed. But if you're having symptoms, as most women are, that relate to bulk or bleeding, menstrual flow, then you're going to be very happy with the improvement that you find.
How much pain will I experience after the procedure is completed?
A lot of you have heard, whether it's on the lay press or from your gynecologist, that this procedure is really painful. That, I think, is a very much an overstatement. Most women don't have nearly the cramps and discomfort that are described to them. It's typically like a bad period, and it happens not during the procedure, but after the procedure is over, typically even a half an hour after the procedure is concluded. It lasts for about 4 to 6 hours. Typically by hour 20, and I don't know what happens then, you turn the corner and the cramps and pain are much, much better. Typically we have a pain pump and a heating pad connected while you're still in the room during your procedure, and that's done so that there are no gaps. Cramps and discomfort are much easier to treat if you stay on top of it. Overall, you'll use less medication and have a quicker recovery than if you wait until you're having cramps and pain that's reaching severe levels and then try to catch up. The reason that we admit you for an overnight stay is because we want to maximize your comfort, and the cramps and discomfort that happen after embolization sometimes is more than what oral pain relievers can handle. And for that reason, I'd rather have you a little bit nervous that yes, this may have a significant after effect, but we'll do our best to make sure that you're comfortable. And I want you to be here so that we can observe you and make sure that you're getting adequate pain control. And most women are ready to go home the following morning after breakfast. If we try to do this on an outpatient basis, I don't want to run the risk that late into the night you're not getting enough pain relief and you need to go to the emergency room. I just don't think that that's the right way to take care of patients. I also don't want you going home thinking you need to cook or take care of your family. Your job when everything is over is to relax, recover, and have support at home who can take care of you. Generally, you will go home on a combination of oral pain reliever, anti-inflammatory, a nausea medicine if you need it, and a stool softener. And in fact, I get a lot more calls afterwards with problems with constipation from the narcotics causing abdominal and pelvic pain than I do about fibroid-related issues specifically. The heating pad is as effective often as the pain pump, and a lot of women have already noted that during their periods a heating pad is really helpful. So the heating pad and the pain pump are hooked up while you're still in the room. If you need extra pain reliever, the pain should never be more than a 3 or 4 on a scale of 1 to 10, then please let the nurse know. He or she is instructed to give you extra pain reliever, and usually within a few hours you've figured out exactly how much pain relief you need, and then the pain pump works very well and your recovery goes very quickly from that point on. What I find at home is not a long period of cramps or discomfort. Typically what women experience is fatigue, and I ask women to take 2 weeks off of work. Generally the first week is getting back on your feet, resuming normal activities, going to the store, but the second week generally the fatigue is subtle, but it's there, and if you can work from home or work part-time, that will be really helpful, because a lot of times you're fine during the day, but by about 3 or 4 in the afternoon you're really starting to run out of steam. So you don't want to do this procedure at a time in your life where you're under pressure to perform. You have a family reunion or a trip planned or some kind of deadline. You really want to give yourself a good period of time to recover. Most of the time the cramps and pain, as I said, are over with in just a few days. I do a follow-up phone call at 1 day, 1 week, 1 month, 3 months, 6 months, and annually thereafter. Typically by 30 days you've had a menstrual cycle, and we can see it's typically lighter than usual, and we can see if your bulk-related symptoms are responding, because most of the time within 3 or 4 weeks you'll notice an improvement in the urinary frequency or pelvic pressure that you were experiencing prior to your procedure. That tells us that you're on the right track. We generally don't do follow-up imaging at that point because it's not necessary. If, on the other hand, you're having cramps, pain, fever, vaginal discharge, those things are not normal after a few days. And I will often get an MRI scan to determine if the fibroids are dead, if the uterus is viable, if there are any other issues going on. You're admitted to my medical service. I want to make sure that you do well post-operatively, and so if you have any problem whatsoever, I really want you to call me and tell me what's going on, as opposed to showing up in the emergency room and having a bunch of unnecessary tests and potentially even being rushed to the operating room for fear that there's a terrible infection going on, and it's actually not a problem so severe that oral or intravenous medications can't take care of it easily. The number of patients who come back is probably less than 10%, and I've readmitted them, given them intravenous antibiotics and pain relievers, and everybody's gone home the next day without the need for an urgent or emergent procedure. So I really want you to contact us if you find that something isn't going right, or you have a question or concern that isn't answered in the booklet that we've given you.
What should I watch for once I've returned home?
You may have heard of something called post-embolization syndrome. What happens after uterine fibroid embolization is a little bit different than that. The cramps and pain that happen occur as a result of the uterus being starved for oxygen and nutrients. This is part of the expected result, and typically it's better after 2 or 3 days. Post-embolization syndrome is something that we recognized years ago when we started embolization therapies for a variety of other conditions, tumors in the liver, tumors in the kidney, and what this is cramps, pain, fever, nausea and vomiting, and it starts typically 2 or 3 days after your procedure is over. You will experience general temperature fluctuations in the first few days after uterine fibroid embolization as a natural byproduct of the breakdown of the fibroids. That's why you're going to be on an anti-inflammatory for 5 days. Typically we use naproxen, and this is regardless of how well you're feeling. The post-embolization syndrome is a higher fever that you will not be able to take care of just with oral medications alone. Risk of infection or fibroid expulsion, those also manifest themselves exactly the same way, and again, you're having symptoms that are not responding to the usual medications. So if you have a slight temperature fluctuation, 99, 100, that's to be expected. It really is imperative that you continue to take your anti-inflammatories on schedule, and those symptoms should be very manageable without really feeling anything other than noticing a slight change in your temperature. If you are experiencing more than that, then I definitely want you to contact us because it may herald something more intense going on. But again, these are usually readily addressable, treatable conditions that don't put you at additional risk for complications. But if you ignore them and fail to let us know and wait too long, then infection or other complications can occur that can become much more difficult to manage. So I really emphasize that pain, fever, cramps, and vaginal discharge are reasons to give us a call and let us know what's going on.
What is the success rate for UFE?
Most of the time when we go to embolize fibroids, we're successful at putting our catheter where it needs to go. The procedure, as I said, takes about an hour. It's very unusual to take a lot longer than that. And we're 88 to 92% successful in general at producing enough relief of your bleeding or bulk-related symptoms that you don't require any further treatment. Technical successes, as I said, are really very common. It's often a variation of anatomy. You don't have two uterine arteries, or your ovarian arteries are doing all the work, and you don't hardly have any blood supply to the fibroids from the uterine arteries, that you need a different strategy. But for over 90% of women, the anatomy is normal, and embolization of the uterine arteries produces the desired effect.
What are the risks involved with having this procedure?
As far as complications go, the risk from uterine fibroid embolization is extremely low. It's a catheter-based procedure, it's really minimally invasive, and the problems that can develop afterwards are really more related to the angiography procedure than they are to the fibroids themselves. Although, as we said, we really want to be mindful of fibroid passage or infection. Those are really the things that could lead to significant complications down the road. You are transiently hypercoagulable. That means your blood is a little more prone to clotting than usual. So we want to make sure that you don't have other predisposing factors, because the other major complication that can occur is clotting of the veins in the pelvis, and the consequence of that, which is pulmonary embolism, which is blood clots traveling to the lung. Fortunately, this is exceedingly unusual, but anytime you are at bed rest and have a minimally invasive procedure such as this, there is always a slim chance that that could occur. So in many women, we will give a prophylactic dose of blood thinner while you're in the hospital for that transient period at which your blood tends to form clots a little more normally than it would otherwise. This is still a very infrequent complication as compared to any of the surgical alternatives. And for hysterectomy and for myomectomy, the complications include abdominal abscess, wound issues, as well as thromboembolism at a significantly higher rate. In general, I tell women that the risk of complications after uterine fibroid embolization is only about 10% of the other treatment options. Still, we take them seriously, and we really want to know if anything unusual is going on.
Have women who have had the UFE surgery done been able to bear children afterwards?
In all of the series, women have been able to become pregnant without any seeming increase in the risks of carrying that pregnancy, but this is an area that really needs further investigation. The current thinking is that if a myomectomy is feasible, that should be the first line of therapy for women with symptomatic fibroids who are desiring to preserve fertility and are actively trying to get pregnant. If you're just trying to keep that option open, I think fibroid embolization is probably as good an option. As I mentioned, it seems that if you can conceive, the pregnancy then goes well, although our recommendation currently is that if you are considering getting pregnant, that contraception be used for 6 months after embolization while the uterus is undergoing this process of healing and the fibroids are shrinking, and then the delivery be done by cesarean section and not through a trial of labor, to make sure that there are no untoward complications such as uterine rupture or some other problem with the placenta after delivery.
Will my sexual experience be altered after UFE?
Sexual function generally is improved after fibroid embolization. A lot of the problems with sexual function are related to the bulk symptoms of large intramural or subserosal fibroids, and the pelvis is a very confined space. If you can shrink and soften the fibroids, sexual function does improve. There have been some concern to the potential for the orgasm to be changed, because a component of the orgasm comes from deep contractions of the cervix and the muscle that is the uterus, and the clitoral stimulation aspect is not unchanged, but the deep aspect may be changed because the uterus will change its will perhaps lose some of its normal responsiveness and contractility during stimulation.
What are the long-term effects of having UFE done?
As I mentioned, the long-term outcomes after fibroid embolization are great for the majority of patients. The recurrence rate is extremely low. If you compare to myomectomy and other uterine-sparing alternatives, the risk of requiring a second procedure is probably in the single digits for women who are within just a few years of menopause. The further out you are, the more time you have to grow new fibroids, and the more likely you will need a secondary procedure. That number is approximately 15% at 2 years. It may approach 20% at 3 to 4 years, and about half the women opt for hysterectomy. They really like to be done with this, and about half of them opt to have uterine fibroid embolization performed a second time. All of your options are open after UFE, including a second UFE, and it seems that the risk of complications after UFE is no greater than if you had pursued some other treatment. So this doesn't close the door to any of your other treatment options. In summary, almost all the women that I see are candidates for the procedure, but I really want to know if their symptoms are due to fibroids and whether or not I think UFE will be beneficial. And for that, an MRI scan is really the gold standard. The procedure itself, as I said, is quite straightforward. It's very well tolerated, and all of the equipment and agents that we use are FDA approved. The radiologist is your primary care physician in this respect, and after your procedure will be taking charge of your postoperative care. Your gynecologist will be included, or your medical doctor, in all decision making, but your interventional radiologist is the primary person to contact if you're having a problem. Long-term benefit has been proven with very few complications and a very high degree of patient satisfaction. I encourage you to speak to people who have had this procedure, speak to your doctor about whether this is a good option for you, and above all, consult an interventional radiologist if you have any questions about whether you are a candidate for uterine fibroid embolization. Thank you.